Chairman Franks and distinguished members of the subcommittee, my name is Anthony Levatino. I'm a board-certified obstetrician gynecologist. I received my medical degree from Albany Medical College in Albany, New York in 1976 and completed my OBGYN residency at Albany Medical Center in 1980. Over my 32-year career, I've been privileged to practice obstetrics and gynecology in both private and university settings. And from June 1993 until September 2000, I was an associate professor of OBGYN at Albany Medical College, serving at different times as a medical student director and residency program director. I've also been in private practice and currently operate a solo gynecology practice in Las Cruces, New Mexico. Thank you for the invitation to address this issue. During my residency training during my first 5 years of private practice, I performed both first and second trimester abortions. During my residency years, second trimester abortions were typically performed using saline infusions or occasionally prostaglandin instillation techniques. These procedures were difficult, expensive, and necessitated that patients go through labor to expel their preborn children. By 1980, at the time I entered private practice, first in Florida and then in upstate New York, those of us in the abortion industry were looking for a more efficient method of second trimester abortion. We found that suction dilatation and evacuation, or suction D&E for short, offered clear advantages over the older installation methods. The procedure was much quicker and never ran the risk of a live birth. Understand that my partner and I were not running an abortion clinic. We practiced general obstetrics and gynecology, but abortion was definitely a part of our practice. Relatively few gynecologists in upstate New York would perform such a procedure at the time, and we saw an opportunity to expand our abortion practice. I performed first trimester suction dilatation and curettage abortions in my office up to 10 weeks from last menstrual period, and later procedures in an outpatient hospital setting. From 1981 through February of 1985, I performed approximately 1,200 abortions. Over 100 of them were second trimester D&E procedures up to 24 weeks of gestation from last menstrual period, equivalent to 22 weeks post-fertilization age. As an aside, the last menstrual period dating system and post-fertilization dating systems are equally valid, and both are found in the practice of medicine and in mainstream medical literature. Most, if not all, embryology textbooks, for example, typically date fetal development in terms of days or weeks post-fertilization. In clinical obstetrics, we use the last menstrual period system. Both are valid. It's only necessary that one specify which system is utilized, and H.R. 3803 does that. Any competent physician can read the definitions in H.R. 3803 and understand exactly where that cutoff line is. Imagine, if you can, that you're a pro-choice obstetrician gynecologist like I was. Your patient today is 24 weeks pregnant, measured last menstrual period as obstetricians typically do. At 24 weeks from last menstrual period, her uterus is 2 finger breadths above her umbilicus. If you could see her baby, which would be easy on an ultrasound, that baby would be as long as your hand plus a half, from head to rump, not counting the legs. Your patient has been feeling her baby kick for the last month or more, and now she's asleep on an operating room table, and you're there to help her with her problem pregnancy. The first task is to remove the laminaria that had earlier been placed in the cervix, the opening to the uterus, to dilate it sufficiently to allow the procedure that you are about to perform. With that accomplished, direct your attention to the surgical instruments arranged on the right. The first instrument you'll need is a 14 French suction catheter. I brought one along so you don't have to imagine it. It's about 9 inches long, it's clear plastic, and there's an opening through the center of it. Picture yourself, if you can, taking this instrument and introducing it through the cervix and instructing your circulating nurse to turn on the suction machine. What you'll see is pale yellow fluid running through the tubing into the suction machine. That was the amniotic fluid that was there originally to protect the baby. You're next going to need a Sofer clamp. It's about 13 inches long, it's stainless steel, and the jaw on this is composed of rows of sharp teeth. You introduce this instrument blindly and start pulling off limbs. Feel yourself grabbing and pulling hard, and I do mean hard, and out pops an arm about that long, which you put down next to you. Followed that by a leg just as long. And then you tear out the intestine, the spine, heart and lungs. Difficult part of the procedure is the head, which is about the size of a plum. You know you got it right if again, this is blind, but you know you've got it right if your instrument's spread about as far as it can go. And you've got a hold of this, and you know you did it right if you crush down a white material runs out of the cervix. That was the baby's brains. Then you can pull out skull pieces. Many times the little face will come back and stare back at you. Congratulations, you just successfully performed a D&E abortion. And if you think that doesn't hurt, if you believe that that isn't an agony for this child, please think again.
Thank you, Dr.